Hi, my name is Nicole and we're going to be doing a newborn assessment today. So as you see, I have my newborn here right here. And first I'll be outside the room confirming the doctor's order for a newborn assessment. And then I would ensure that I have all my equipment and that I perform hand hygiene before going into the room. And then upon entering the room, I will greet the parents of this child, and I would confirm the patient's name and date of birth and make sure that it also matches mom or dad as well. And then we'll get more information as far as birth history. So how this baby was born, whether vaginally or C-section, if there was any trauma during the birth, how fast the baby came out, how long labor was. And this baby was born vaginally and full term. So that's good to know. And then I would go ahead and do some vital signs. So I would do temperature, pulse, and respirations. And I would listen for the full minute. And I would also listen to the baby's apical heart rate. But first I'd listen to respirations for a full minute. And then apically I would also listen to for a full minute as well. Okay. Then I'd also listen to see if I hear any murmurs or anything like that. All sounds good. And then we're gonna go ahead and start measuring our baby. So first I would do the length. So this starts from the top, I'll do on this side, the top of the baby's head all the way. They wanna curl up, so just trying to have them as straight as possible. You know, they'll be moving around. About 43 inches this baby is, which is not very accurate for a baby. And then I would also get the baby's weight and then head circumference. So at the back, all right, then up here. Okay, and then I would also do at the nipple line, the baby's chest circumference as well, if I can get it around. All right, at nipple line. And then general appearance for my baby, pink, warm and dry skin, very vigorous, loud cry, muscle tone, baby is moving around, reacting, grimacing, making expressions, which is all very good. Then I'm looking at body alignment and symmetry, seeing if everything lines up and looks normal, which it does. And then also the baby is covered in Vernix, which is a white cheesy substance that protects the skin during birth as well. And I would also look at Melilla, which is the small white bumps on a baby's nose or chin, and these typically go away. These are normal to have, as well as fine baby hair, also known as lanugo. And then I would also check for erythema toxicum, which is baby acne, which can be due from environmental factors. And then I would also check if the baby has any Mongolian spots, which are typically on the back side, shoulders, buttocks of the child. And this patient does not have any Mongolian spots. And then I would also check for petechia, which is the small red pinprickles that can happen as a result of like trauma during delivery if the baby came out too fast. And this baby does not have any of that, thankfully. And then so starting at the head, I'm assessing the baby's fontanelles. I am looking anterior and posterior, seeing if they're flat or sunken at all, which can be too little or too much fluid. And then also I'm looking at the molding, so looking at the sutures on the top of the head as well. And then also looking for any cephalhematoma, which is if there's a blood clot or anything at all for the head. And then also looking for cap cut if there's any generalized edema for this baby. And then while I'm here at the head, I'm assessing the patient's face. So I'm assessing for symmetry, just making sure that the eyes, nose, everything is even and matches. Same for the baby's ears. And also checking that they're well formed, that there's no tags, and also that they're aligned with each other, which it is for this patient. And then for the nose, which look at the patient's, make sure it's patent bilaterally, and the narratives are also even and patent. And then for the mouth, I would have gloves on, of course, but I would stick my finger a little bit inside the baby's mouth to feel for the hard and soft palate to ensure that it is in fact intact. And then I would also check for Epstein's pearls, which are calcium deposits in the mouth, and those typically go away. And then I would observe whether the baby is able to suck or swallow while the patient is being fed. And then moving on to chest. So it looks normal and symmetric. I do notice a little bit of budding in the nipple area, which is normal. I don't see any engorgement or anything with this patient, or anything out of the ordinary. And then when I did listen to breath sounds at the beginning, they did sound a little bit wet, but that is normal, especially since this baby was just born. There's still going to be some fluid in the lungs. And then for the neck and clavicle, I'm just feeling and inspecting that nothing's really out of the ordinary. I know babies don't really have much of a neck or collarbones at this stage. And then for the patient's abdomen, I'm inspecting, looking at the umbilicus. I'm looking at the core, making sure that there's no sign of infection, that it's starting to dry up. And I also am noticing that there's 2 arteries and 1 vein. And then I'd also listen to the bowel sounds, which this baby has not really had much of anything to eat yet. So there is no bowel sounds that are active for this patient, which is completely normal. And once the baby does start eating, then the baby will, elimination, have some voiding, and also we're looking out for any meconium once the baby does have its first stool. And then I would look at genitals, which we'll take this diaper off, of course, make sure that the parents are consenting, of course, okay with this assessment. And since this patient is a female, I'm assessing for any discharge that she may have. And then I'm also making sure that her labia covers the clitoris area. And then if this patient was a male, I would make sure that his meatus location was central to make sure that he is able to urinate properly. And then I would also see the testes location, make sure that everything's in order, and that I would palpate the scrotum for any rugae. And then I notice that all movements are equal and bilateral. I'm not noticing anything out of the ordinary for this patient. And then patient also has all of her fingers and toes, which is great, and seems to have great range of motion, arms and legs. And I'd also check the hips while moving the legs. It's kind of hard with this doll, but moving the legs up and back. I'm trying to listen for any clicks or pops to see if there is any dislocation with the hips, and everything is fine. There's no popping. In the feet, there's also no clubbing for this patient. And then I would turn the patient over and I would assess the spine, look for any spina bifida, and also just make sure that it's all aligned. And then while I'm down here, I would also ensure that the patient's anus is patent and able to contract as well. And you'll also see that once the patient obviously starts having bowel movements as well. And then going on to the reflexes, so checking for Moro reflex. This is a startle reflex. So if I were to place the patient in the crib and kind of move away, not exactly let the baby fall, of course, but it'll feel like that for them, and they'll flail and kind of be startled. And then tonic neck. So If the baby is looking over here, turning its neck towards me, its arm would be reaching out in the same direction towards me. And then palmar, if I grab baby's hand, it's gonna curl its fingers around my finger. And then plantar, same thing for the foot. If I put my fingers up against the foot, the toes will curl around. And then I can also do Babinski on the foot. So if I move up, the toes should flare out for a positive Babinski sign is what I'm looking for. And then also I'm looking for any rooting. So if I touch the cheek, will the baby turn its head and look for the nipple to suck? And then, as I said earlier, with the sucking and swallowing, I would observe that while the patient is with the parents eating. And then, if for stepping, obviously if I would have the baby up and then see if the baby starts to try to move its legs in a kind of stepping motion. And then I would observe the patient's trunk curvature on the back. Just see that it curves into the side as you rub. And then as far as the behavioral state for this patient, the baby is actively crying. You can't hear it, but she is. She is active alert. She's crying a lot, but it's a good, vigorous cry. It's not a very intense cry to where I worry that something might be seriously wrong. And I'm also assessing if the patient goes into deep sleep, light sleep, gets drowsy, and anything like that. And then I would, of course, just talk with the parents and see if they have any other questions or concerns about their child. And then that's it. Thank you.